and Jam!
For today's Cram, we're talking about the respiratory system.
And for today's Jam, we don't know what it is, but we did just film a crazy dance sequence with no music and a dog.
Yeah.
Yeah.
And there's a uterus.
On our poster.
Here. Cool.
So
anyway,
I'm Ashley.
And I'm Christopher.
And we hope you've enjoyed the show. How did it look?
That was a bad one.
Oh! Hello there!
We're just eating our grapes and I'm just showing in my underwear. Hey.
If you couldn't already guess, this is Cram and Jam. And today, we're in a toga paradise. Mount Olympus, in fact.
Yes, actually.
And we're going to be doing the respiratory system today with the dog. And if she gets too annoying, we'll put her away.
She wants a break.
But they're poisonous, so she can't have one. Okay. But she's really cute, and hopefully she'll behave herself.
Okay. So, first we're going to be talking about asthma, which is an obstructive lung disease.
Christopher has asthma.
I do. What should we say about asthma?
Yeah, we don't have a lot to say about
We
asthma.
have the asthma drugs. Basically, we all know what asthma is. You can get an asthma attack.
It's like a bronchospasm.
Right.
You would hear wheezing.
The
The more wheezing you hear, the better the asthma attack is getting. No wheezing means you're not living in at all.
Right, yeah. If you, whenever you listen to their lung sounds, they can also be having diminished lung sounds. You don't actually have to hear wheezing for them to be having the asthma attack. So first treatment for asthma would be bronchodilator, which is like a rescue inhaler. And it's albuterol, pretty much. And like
We
this.
have one here.
How
I'll
convenient.
bring it a little closer. I get a lot of bronchitis. I'll even show you how to use it, even though I don't need it right now, which is a no-no, but I'm still going to do it. So, put it in your mouth. Wait a minute. I think you take a deep breath first.
Yes. No. Blow your breath out. Okay, you have to puff and inhale at the same time.
I feel so alive! Alright. That was me taking my
Just like that.
unnecessary drugs.
For people that can't puff and inhale at the same time, which is actually very difficult to do.
Right.
It is actually hard. You can get a spacer to put in your inhaler. It's like a tube that goes on the end, so whenever you puff, all the medication goes in the chamber, and then you can just inhale it at your leisure. But the bronchodilators, which are albuterol, there's Provincial, Ventolin, and ProAir. There's no generics. There used to be, but they were bad for the environment, so
they changed them, and now there's no generics.
Yeah.
So the environment is saved, but it's not your pocketbook.
Yes. Next, after the bronchodilator, if they're still having asthma issues, you could try an inhaled steroid like Flovent, Pulmicort, and Asthmanex. And
an important thing with those is if they're using an inhaled steroid, they need to rinse their mouth out after they use it, or they could get oral candidiasis, also known as thrush. So some important patient teaching.
Yeah. Next, you would the next step would be a long-acting bronchodilator like Ceravent or Floridil. Honestly, I don't think they prescribe just the long-acting very often.
I've never heard of them before.
Yeah, but they do use them in combination therapies. A combination inhaler, which is what they prescribe more often, is an inhaled steroid and a long-acting bronchodilator together. And those would be like Advair, which I'm sure everybody's heard of, Dulera, and Symbicort.
They also use this for COPD, which we'll be talking about next.
Yes. And they can also try leukotriene, which is if their asthma could be brought on by like by an allergen, and that would be like Singulair or Accolate, but Singulair is definitely going to be
the one you'll probably see at the test.
Yeah.
It's the one that's more common. I've eaten commercials for them.
Yeah. And then there's anticholinergic medications, which are usually given with asthma. They're more given with COPD to dry up secretions. Those would be like Spiriva and Combivent, which is tiotropium. And, yeah.
Yeah. So those are the drugs we have for asthma. Sorry we don't have more pathophysiology, but
we know what that is.
we know what asthma is.
They can also give theophylline, but they don't use it very often anymore. But if you're taking theophylline, you need to monitor your levels.
If you're working in the ER, you might see theophylline used. Be like a last ejector drug.
GERD can trigger asthma attacks.
We talked about that yesterday in our GI one, and that is because if you are aspirating the stomach acid, it can irritate and cause bronchospasm.
Yeah.
So, interesting one to say.
Okay, so next we have COPD, which is also an obstructive lung disease.
Obstructive can't get air out. Restrictive can't get air in.
Yes.
Correct? Okay. I wanted to clear that up.
Yes.
COPD. Chronic obstructive pulmonary disease. It tells you what kind it is right there in the name. It used to be known as emphysema. It's most often caused by smoking. And once again, we have our package of Marlboro Lights, which we did not purchase just for this.
No.
But we don't smoke. We just had them.
At my house. I don't know.
I mean, there's lots of things around your house. It can also be due to alpha-1 antitrypsin. I don't know what that is, but it is in the notes. And so you can have emphysema.
That's if you have like an inherited, genetic. If you have a genetic case of COPD,
which you could also have.
Yeah.
So you have emphysema, which would be like a dry COPD, and chronic bronchitis, which is a wet COPD. You should look up the definitions on the PowerPoint if you are unsure of where we're going with that. And it can also be caused by chronic irritants, like smoking, or asbestos, or dust, that kind of thing. So you have some chronic coughing. The problem can be from below, which is acid reflux, refluxing and aspirating stomach contents. From above, you can have postnasal drip or allergies, and then you might have the intrinsic COPD, where you just have like a really reactive airway. Some people do. Their airways get excited about silly things like Skittles. Because the cilia that are in your mucociliary lining of your respiratory tract are kaput from smoking, they have died, there's an increased risk of infection because you're not moving those secretions. And so what you want to do with COPD is promote the clearance of secretions. So you can do that vest thing that shakes them.
You can use medications.
Like
fluid.
Expectorant.
Yes. You want to make sure they have enough
fluid.
So.
And you're going to want to control infection. If there is an infection with antibiotics, provide adequate nutrition. And if you're going to do a health history on a COPD patient and ask them about any recent infections, cough, if it's wet or dry, speak to them, how much, what color, what town is it from, family history, dietary intolerances, weight loss, large frequent bowel movements. I think this is about cystic fibrosis. These pages are wrong. So, COPD, where the heck did those go? Pause. COPD. Like the rest of it's all in order. We might not really have anything else to say about COPD. That might have been all. We might have lost a page too. Oh, no. COPD. There we go. We're good. All right. All the things that I said about COPD were actually about cystic fibrosis, but they also apply because it's just sort of general things you do for people with airway disorders.
Yeah.
So because of going back to that mucociliary thing I was talking about, bacteria and excess mucus gets trapped. As we get older, also, do you know what happens to our alveoli?
They
well, if you have COPD, I guess maybe not as you get older. Little balloons. Not snapping back like
they lose their elastic recoil.
And so you can also have a chronic infection, which will cause remodeling and obstruction and vascular changes. Gross. Pulmonary hypertension, another problem we see with COPD. When the right-sided pulmonary artery has increased pressure from the heart, causes right-sided heart failure, or it puts increased pressure on the heart because And so you get right-sided heart failure, breath sounds decreased. You may or may not have wheezes, a barrel chest, or cyanosis. But with COPD, you usually do see a barrel chest, which is an antero-posterior ratio of 1 to 1, like they look like a barrel. Usually it would be 2 to 1.
And you can also have clubbing of the fingers. You know what those look like? Yeah. They have like a spongy feeling nail.
Cyanosis.
Like in their nail beds.
Peripheral cyanosis. They may have orthopnea, where they need to be sitting up to breathe or bent over a table,
which is called tripoding.
Yes. And they may do pursed lip breathing, which is good because you want to teach them to do that anyway, because it forces the alveoli.
Yes, the positive and expiratory pressure.
Yes. Beep. Yes. So if you're going to diagnose COPD, you're going to do AEGs, pulmonary function tests, pulse ox, chest X-ray. The forced expiratory volume is decreased. So how much air they can get out of their lungs, like,
which you could check with a peak flow meter.
Yes, is decreased. But the total lung capacity is increased. They can get a lot of air in their lungs because their alveoli are huge, but they can't get it out. So, yes. On an ABG, you would show low oxygen and acid and high carbon dioxide and bicarb.
And that has to do with the fact that they can't get the air out. So it's all just chilling out inside their lungs.
And so with COPD, if you're going to put them on oxygen, you cannot put them on more than 2 liters using cannula. Because what happens is there's this process, and it ends up being that the CO2 levels are what stimulate them to breathe, not the O2 levels. So if they have high blood oxygen, they're not going to breathe as much. So that would be a bad thing. We don't want that to happen. So
breathing is good.
Breathing is awesome.
Unlike joints and appendixes,
joints and appendixes, and gallbladders.
They're all bad.
We don't like those. Breathing
is good.
Excellent. Treatment. You could do most of the same drugs we talked about for asthma. They may need oral steroids. So all the things that go along with oral steroids there. Bruising,
increased risk for infection. Cushing syndrome.
And then that pursed lip breathing we were talking about, where you might not have been able to see that, but whatever. It acts like a CPAP would, and it increases that positive end expiratory pressure. You can also use percussion, where you're patting them on their back.
Yep, we'll demonstrate a little bit for you.
On the back, and postural drainage, which is where you like turn them upside down and let it drain, which just sounds so uncomfortable.